Okay, ladies and gentlemen, I would like to start this session. So in the next 90 minutes or so, we will talk about extending the options to address evolving needs in TAVI. And if there is one slide, then it will be the overview of the session of today. And it's this one. But just to set the stage a little bit, a couple of weeks ago we published in the European Heart Journal a manuscript where we estimated the total volume of TAVIs based on current guidelines. So as you know, the current guidelines recommend TAVI in patients at intermediate, low, or inoperative risk. And based on those calculations, you would end up with a global annual volume of 180,000 TAVI procedures a year. And that would extend or expand out to 388,000 if we move to the lower risk patients. And as you all know, next year we will see the presentation and hopefully also the publication of two large low-risk randomized trials. So basically, this puts our TAVI programs to some kind of attention because we need to deal with a growing number of patients, growing number of candidates, and that poses some logistic challenges. Challenges that are on our TAVI procedure, but also on the way we follow up our patients after the TAVI procedure. And what we will do in this session is first address some accessories to reduce some of the dreadful complications, notably neurovascular or neurological events, predominantly important, I think, because we are moving to the low-risk patients. And then we will check some expanding access options in patients with the challenging anatomies. We look at the current evidence in TAVI using ACURATE and LOTUS platforms. After all, we are in a Boston Scientific sponsored session. We'll see how we close the evidence gap in emerging TAVI populations. And then we will illustrate how to streamline a TAVI program using a recorded case. So with that said, I will introduce the next speaker. And that is myself. So I'm an interventional cardiologist from the Thorax Center, University Medical Center in Rotterdam. And I will, in the next 15 minutes or so, try to explain why there is a need for cerebral protection in transcatheter aortic valve implantation. These are my conflicts. And this is to set the stage of this topic, the stroke risk with cardiovascular procedures. If you look at the CABG, with CABG is around 1.34%. Off pump, on pump it's 2%. With surgical aortic valve replacement, it varies depending on the studies between 1 and 5%. And if we then focus on TAVR, still it is reported to be on average 3.3%. And where does that come from? Well, if we are manipulating wires and catheters in the aorta and in the aortic root, then some debris may release and go and travel to the brain, but also there is a risk for hemorrhagic events, neurological events, because we are using all these kind of blood thinners. And there is also the risk for global ischemia during the procedure, as for instance, we are influencing the hemodynamics of the patient. If we look at the stroke, at the kind of strokes after TAVI in our practice in Rotterdam, then we see the predominantly infarcts are cortical infarcts, and they have an embolic origin, but there are also lacunar infarcts and hemorrhagic infarcts, and in some of the cases, it's an undetermined infarct, but most often that also is an embolic infarct. With current day devices, the 30-day all-stroke rates is not zero. And this is illustrated in this particular graph, where you see that with Lotus, with Evolute and CoreValve, with the Evolute Pro, also with SAPIEN 3, the risk is not lower than 2% in principle. And then there is also an outlier, and the outlier is the Sentinel trial. The Sentinel trial was a randomized trial comparing the use of cerebral embolic protection during TAVI, using either S3 or Evolute. And patients were randomized to cerebral embolic protection or no protection. And in the control arm, the neurological event rate was 9.1%. Why would we have that outlier? Well, probably if you invite your neurologist to be part of a study, then they will find events that seem to be more subtle than what a cardiologist can identify. So basically, this is what we're seeing in our current practice. And with growing experience, you see a clear reduction in life-threatening bleeding and major vascular complications. But somehow, the stroke rate in Rotterdam, Toulouse, and San Raffaele doesn't seem to change that much over time. And this is also echoed in the recent report by the TVT registry. What you see is, based on increased procedure volume, so the increased number of procedures, that the mortality is dropping, vascular and bleeding complications is dropping, but again, the stroke rate is not changing. So what's going on there? Well, we know that the stroke after TAVI predominantly occurs within the first 24 to 48 hours. After that time period, there is a different reason why we would do strokes. So in the first 24 to 48 hours, it probably is due to a procedure-related thrombus or debris that embolizes to the brain. Within the first 30 days, there are some reports that point towards the new onset atrial fibrillation as a predominant cause for stroke. And then after 30 days, we have the classical risk factors with atrial fibrillation and lacunar infarcts. So the timing after TAVI is predominantly within the first 24 hours. That has been reproduced in several registries and single-center studies. But there is more to it than just clinical events. There is also the issue of new brain lesions, brain injuries, so to speak. Because if you do an MRI before and after a TAVI procedure, you will see, on average, in 80% of the patients, new brain injury. And that doesn't mean that these patients have clinical events, but it does mean that there has been an insult to the brain, like, for instance, a commotion after a car accident. So the brain has been shaken up somewhat, and the question is, okay, will a patient pay a price for this brain insult? Well, that is the remaining question that we are facing today, and probably if we are just treating 80-year-olds, then patients will not live long enough to experience the effects of that particular insult. But if we're moving to lower-risk patients with a longer life expectancy, this kind of injury may come back to haunt them. Because silent infarcts are not trivial, and they have been associated with impaired mobility, physical decline, depression, cognitive dysfunction, but also dementia. So new brain lesions assessed by brain MRI, as I mentioned, not always clinically evident, but if you then check for instance, delirium, which is quite often seen in the elderly patient populations who are currently treated with TAVI, then if you look at brain MRI before and after, and then compare the patients who had a delirium or who did not have a delirium, then you see that the total number of lesions is higher in the patients who had a delirium. So that is another indirect indication that these so-called brain lesions may not be that innocent. So the sources for debris during a TAVI procedure are various. It's, of course, the calcified valve with the leaflets. It's also the calcified aorta with all kinds of atherosclerotic plaques that we encounter, but also the myocardial tissue. Because as you all know, we are working over the wire, so there's a stiff wire in the ventricle that probably is moving back and forth and scraping against the myocardial tissue. And we do see, but I'll get to that later, but we do see myocardial tissue in filters. There is also a correlation between arc atheromata, so atherosclerotic plaques in the aortic arch, and the risk for neurological events. We know that from the general literature that if you look at patients with aortic stenosis and compare them to control, patients with aortic stenosis, they have more aortic plaques in the aortic arch, and also more complex plaques. And these complex plaques, they again are associated with cerebral infarcts during and also after the procedure. So basically, arch atheromata are an issue in patients undergoing TAVI. The procedure itself, as mentioned, is associated with debris dislodging and embolizing to the brain, and it predominantly occurs during the positioning and the implantation of the valve. And this is data that already goes back to 2012 when it was published in Circulation. So this is the concept. If you would implant a valve and you would use some kind of a filter protection, you might end up capturing some of the debris that might result in a reduction in new brain lesions that then again might affect cerebral performance and neurocognitive performance after the procedure. There are several ways of protecting the brain, and to keep the balance, there are filter-based protection devices and there is also deflection devices. I will focus on filters, but I do believe that we have to mention embolic deflectors. There is a Deflect 3 randomized study that was published in the European Heart Journal that also demonstrated less worsening of the neurological or the National Institute of Health stroke scale in patients who were protected with TriGuard, and also there was more freedom from ischemic brain lesions in the protected patients. There was also an effect in change in some kind of the neurocognitive scores that were applied. More evidence is available on filter-based embolic protection, and this is the Claret first-in-man filter device that later was emerged or evolved into a Sentinel filter, which is based basically in two filters. One filter will be deployed in the common carotid, in the left common carotid, and the other one will be deployed in the brachiocephalic trunk. Basically, you protect two of the contributory vessels to the brain on the right side and the major vessel on the left side. So 3 out of 4 vessels that are responsible for the blood flow to the brain are protected using current generation filter-based protection. There are some randomized trials that have investigated the role or the effects of these filters and especially the effects on brain injury. There's the Mistral C from Rotterdam, there is the Clean TAVI from Germany, and there is the Sentinel trial, which is a larger randomized study in the United States. The issue with these MRI-based TAVI trials was that overall the observed lesion volume was lower than expected, and there was a high variance across the valve types. But is there a real difference between the valve types? That's one of the open questions, but there was a significant MRI dropout in these patients. And that is a matter of concern, because if you're using MRI as your endpoint and you also expose octogenarians to an MRI before the procedure, a lot of them are fed up with their MRI after the procedure. So they are not inclined to undergo another MRI within 5 days after the procedure. And that is why we have seen this high dropout rate in MRI follow-up in these trials. And that, of course, affects the interpretation of these studies, but also it ended up being underpowered. So the studies ended up being too small, and then, okay, there are some statistical ways to deal with that. And one of them is to do a meta-analysis and combine all the patient-level data. This has been done. This is one meta-analysis where there was, based on Clean TAVI Mistral C, overall a clear reduction, a significant reduction in change in new lesion volumes in the protected territories. This is also echoed in the total new lesion volume in the protected territories in this slide, where you see a 40% reduction in the new volume. And if you compare self-expandable and balloon expandable, it seemed to be that balloon expandable was associated with less brain lesions, but the effect of the filters was also in the patients undergoing balloon expandable. Also, it is important to say that these trials were not sampled to discuss a difference in effect between different valve platforms. The issue with new brain lesions is that there is no correlation between the volume of the brain lesions and clinical events. And this is illustrated in this slide, where all 3 of these control arm unprotected patients from the Sentinel trial had clinically apparent strokes. Look at the MRI. So in this particular patient, he just had bad luck. Debris ended up in a critical zone of the brain, and still he had a major stroke. The meta-analysis, there's also a meta-analysis looking into the clinical effect of the embolic protection devices. And this is a combination of all kinds of any kind of embolic protection, including deflectors. And there you see again that there is a significant improvement in clinical outcome in the patients who undergo protected TAVR, with a number needed to treat of 22 patients to prevent 1 stroke or death. In Sentinel trial, again the largest randomized trial, there were also numerically reductions in neurological events As you see at day 1, there was an absolute reduction of 3% in favor of the protected patients. Unfortunately, the patient was not powered to comment on clinical endpoints, but still, I think numerically, the trend is clear. So what would you find if you use these filters? Well, this is what you can retrieve. So it looks quite variable. But what we typically do in Rotterdam is we send all our filters to the pathologist, because we were interested in, so we were asking ourselves, so okay, if you would use these filters, what would be in the filters? Is it just thrombus, or is it just valve leaflets or parts of the valve leaflet? So what is it? So I was curious. So when I started using these filters, I immediately sent all the filters to my pathologist. And in 2013, we published in Circulation that indeed 3/4 of the patients had debris in their filters. This was not macroscopic debris all the time. It was also microscopic and microscopic. So there was thrombus, there was aortic valve-related tissue, but there was also valve tissue, and there was also, in our follow-up study of the Mistral, we also identified myocardial tissue. So 1 in 3 of the patients had myocardial tissue in their filters. So without a filter, we would have contracting tissue in the brain in 1 in 3 of the patients. Of course, not true, but there would be myocardial tissue there. I don't know if it would contract in the brain. That said, so in 91% of the patients, there was some kind of tissue. In 100% of the patients, there was debris. Our data were also echoed in the Sentinel study, where there was debris capture in 99% of the patients. And again, there was myocardial tissue, there was calcified tissue, there was also foreign body material coming from the delivery catheter or from the valve itself. Predictors for tissue embolization, because the question then arises, okay, but should we then identify the patients who are at risk for developing new lesions or embolizing debris to the brain? Well, we looked into that, and we found that in our study, in our initial series, the use of balloon expandable valves was associated with more debris and larger debris. Also, if we would do balloon post-dilatation, there was a trend that there was also more debris going to the brain. Further analysis that was recently published in JACC Cardiovascular Intervention from the Sentinel trial seems to allude to the fact that there is no real difference between the different devices. So you will find any kind of debris with any kind of valve platform that you're using. Also, if you look at the particle size, then again, you have large particles of more than 1 millimeter in more than 50% of the valves being used. So that's quite impressive. Then you would say, okay, but if we would only use the filters in patients who are at the lower risk profile with a lower STS score, these are the grays, and you would avoid using them in the patients with STS score below 4, the so-called lower risk patients. Well, it doesn't matter. So debris is no different in patients with an STS below 4 or an STS above 4. So there was any debris found in all the patients, regardless of the STS score. Then let's briefly move to some clinical data, some more clinical data. And this is the first series that was presented by my colleagues from Ulm, Germany, where they find, if they compare the protected patients with the unprotected patients, and this is not randomized, trial data, but still, they compared all their patients with protected, with the non-protected, and then they did a propensity matched analysis. They ended up with seeing a 70% reduction in the 7-day all-stroke rate. And that is, I think, an important difference. Why would you look to the stroke rate at 7 days and not at 30 days? Well, that exactly is because we are specifically focusing with embolic protection on debris that dislodges during the procedure, and that will probably disclose itself within the first week of the procedure. So it's hard to understand whether the use of the filters will affect strokes after 1 week. We also echoed that data, and this is data under review at the moment from Rotterdam, where we again see that there is a reduction from 5% to 1% in the patients who underwent protected TAVI. Cerebral embolization during TAVR is not only happening in those so-called protected areas, it's also happening in unprotected areas. And that triggered our center and also thinking about complete filter-based protection. So we did a couple of cases where we introduced the Sentinel filter and then added an additional filter in the left vertebral artery. Interestingly, when we looked into the filters and we compared the filters in the left vertebral artery with what we could find in the Sentinel, there was no difference. We find the same kind of debris in all the filters, so also in the otherwise unprotected left vertebral artery. Also, the debris size was similar in what was captured in the Sentinel versus what was captured in the protected left vertebral. This is another illustration that not only TAVI patients are at risk, also when you would, for instance, consider doing a sapien valve implantation in a patient with a heavily calcified mitral annulus and mitral stenosis, then you also might end up capturing calcified debris in the filters, as we did in this particular case. There is more data in over 1,500 patients nowadays where it's clear that filter-based embolic protection will capture debris not only in TAVI patients but also in patients undergoing mitral valve procedures and in patients undergoing left atrial appendage closure. So that is one of my final slides is, okay, so if it's very difficult to identify the patient that would be at risk, and still you would like to be selective, then answer me this. My pathologist always tells me that a calcified valve, it resembles porcelain. So if you drop porcelain, how can you predict the size of the pieces? Well, this is exactly what you will face with a calcified valve. If you deploy a valve and something is dislodged from the leaflets, at this point in time, you cannot predict the size of the debris that will travel to the brain. So to conclude, in my practice, I use embolic protection in 85% of my cases. Why? Because I think the mechanistic concept is sound and valid. It's relatively easy to use with limited extra radiation. It takes about 90 seconds to deploy the filters, and I don't need any contrast when I use them. Also, embolic protection devices are safe. There haven't been device-related complications in the randomized trials so far, and also not in my current practice. And I typically use it in all my TAVI patients because the debris size is unpredictable and there is clinical benefit. Thank you for your attention.
Nick, thank you very much for this perfect first talk. I'm sure that there will be questions from the audience, so please feel free to come to the microphone and ask questions. And likewise, the panel, if there are any questions. Thomas.
Nicolas, great presentation. You said use it in 85%. What are the 15% you're not using it?
Yeah, so what we typically do is we do pre-procedural CT planning in all our patients, and we also do an evaluation of the aortic arch. And we want to see what the takeoff is of the brachiocephalic trunk and the left common carotid. So we want to know whether it's a bovine arch or not. And also we simulate the anatomy and we simulate how the anatomy would look like at an LAO 30-degree projection. So that helps us to identify the landing zones during the procedure. Sometimes, so a bovine arch per se is definitely not a contraindication, but sometimes the size of the vessels is too large or too small to accommodate the filters, and that is one of the exclusions. Another exclusion is if the road towards your landing zone is too complex. If there is excessive tortuosity, that might be a problem, but you can anticipate based on your CT scanning. And the third one is if there is protruding atherosclerotic disease in the landing zone, then probably you might end up dislodging plaques during the deployment, and you should avoid that as well. So that more or less accounts for the 15% of the patients.
Congrats for your bright presentation. I think that the issue is very complex because we have to consider at least two things. The one is the risk of stroke that you explained before with your question. The other point is the risk of the patient undergoing TAVI. So could you tell us a little bit more about this interaction between the risk of the patient where you perform the TAVI, that means moving from partner 1 to partner 2, etc., you have a drop of the rate of stroke rate, and you don't have any difference with surgery. So the baseline risk of the patient matter, but there is also another risk that is probably disconnected to this one. That is the intrinsic, inherent risk of stroke. So what do you think that in perspective, going down to very low risk patient, do you think that this need increase or decrease? Should we go with Sentinel, etc., only for very high-risk patients, or you think that it is more important to think at lower-risk patients?
Yeah.
Looking at the number needed to treat also, not only to the fact that they use or not.
So as the risk profile of the patient in general goes down, also the risk of complications goes down, including neurological events. But that counts for surgery and that counts for TAVI. If you look at the randomized trials, the high risk going to the intermediate risk, then you see that the overall neurological event rate goes down, but it seems to be in favor of TAVI. So as you move to the low-risk patients, the neurological event rate in TAVI, at least numerically, becomes lower than surgery, whereas in the first partner trial, as you all know, TAVI probably was associated with more neurological events than surgery, and that was unexplained at that time, and that definitely also triggered the development of embolic protection. That said, I think that I illustrated also with a couple of slides that based on the STS score, you cannot identify the patients who would not benefit from filters in terms of debris capturing. So you would capture debris in patients with low STS scores and high STS scores. And that brings me to the point why I believe that also younger patients and lower risk patients would benefit from cerebral embolic protection, and that is that you will capture debris in all the patients. So if you would do an MRI in all the patients, you will see brain injury in 80% of the patients. And then the question becomes, okay, but if a patient has a life expectancy of 20 years or 15 years or 20 years, would you want to take the risk that this brain insult will affect his neurocognitive performance down the stretch? And I think that will be very hard to study, that benefit. But then it becomes for me like a seatbelt phenomenon. You know, when you drive a car, you wear your seatbelt. When I implant a TAVI, I will use cerebral embolic protection, definitely in younger patients.
I would like to challenge you and perhaps Thomas a little bit, because the very first slide you showed that the stroke rate may even be higher in conventional surgery, 1 to 5%, in comparison to, let's say, 2 to 3% in TAVI. Is this what we are now talking about, the filter, the embolic protection, only for TAVI patients, or is it perhaps even more important for patients undergoing conventional surgery?
Well, I'm not sure whether it is more important in patients undergoing surgery. I do think it makes sense to use them in patients undergoing surgery, but it hasn't been studied as good as it is with TAVI patients. But in the surgical population, when you do an MRI before and after, also there in 50% of the patients, you see new brain lesions. And there are some studies that suggest that the debris size is somewhat bigger in surgical patients compared to TAVI patients.
Well, you're 100% right, Helge. You need to look for solutions for all patients, and this includes cases that are operated conventionally, especially when they're younger. So the negative thing is that there wasn't so much investment into that direction to conventional surgery, and therefore we don't have good devices. As good as a Sentinel, for example, where you showed very nice study data.
You could use a Sentinel as well.
You could, yes, but you don't have fluoro in the OR. You're not trained on those devices in an end. And I would think about an easy device that we are on the aorta, we could easily place something into the truncus and the left common carotid, and any filter that would be in the integrated version much easier.
Yeah, and I also see some logistical issues with using the current generation filters in all surgical patients, because then, it requires radial access, and, radial access, it seems trivial, but it's not as easy for everybody. So I think there is a learning curve, and the question is whether our surgical colleagues are willing to undergo that learning curve.
I'm sure. Nick, thank you very much. And we now have discussed the first important issue, stroke. We are now coming to the next important issue, bleeding and access site complications and how to avoid them. And Andreas Rück is going to give a talk about expanding access options in patients with challenging anatomy.
Thank you very much for the invitation. I have a couple of cases to show and also some local data from our center in Stockholm, Sweden. So can I have the slides on, please? Sorry. Yes. Good. These are my conflicts. So to the title, Challenging Anatomy, that could mean quite a lot of different things. If we start from the aortic valve level, it could be an unusual anatomy, like the bicuspid anatomy. It could be highly calcified annulus or highly calcified leaflets. And then going to the aorta, it could be a horizontal aortic ascending aorta, the so-called Gothic arch. It could be tortuous, for example, in the abdominal aorta. And then going to the femoral and iliac vessels, these could often be narrow, calcified, or both, and also tortuous. And one question is, of course, which is your threshold when you switch from femoral to non-transfemoral TAVI cases? I think that's quite different from device to device and also from center to center. And I think there is some data out showing that the transfemoral procedure in general is more safe than a non-transfemoral, so there might be a case for trying to have the transfemoral rate as high as possible. You would see two cases using this valve, the Boston ACURATE Neo valve. It's a nitinol self-expanding stent with the porcine supraannular leaflets, which usually give quite low gradients. It is available in 3 sizes, and it covers annulus from 21 to 27 millimeters. It is delivered through a 18 French flexible delivery system. And as you will see in the cases, the deployment is a bit different from the other nitinol products out there, the so-called top-down deployment in 2 steps. This sheath is quite new since the beginning of the year with CE mark. It resembles a little bit the Edwards E-sheath, which also has passive expansion. This sheath is 14 French insertion profile. It's hydrophilic. It has 3 folds instead of the Edwards, which has 1. It's the same sheath size for all size valves. It's used in quite many European centers, but I think it's not completely available to all centers in Europe yet. We have collected data in our own small registry with 48 patients so far, and we'll soon be up to 60 patients in total. The idea was to collect patients in basically 2 strata, so either the normal-sized femorals, which are 5.5 millimeters or above. As you might know, the instructions for use for most of the current systems on the market state that you should use them in femorals 5.5 millimeters or larger. But we have also included patients with smaller femorals, and that's down to 4.0 millimeters. So far, we have collected 11 of these patients, and we'll soon be up to 20 of these patients with really narrow femorals. In total, in this registry, we have so far only had 1 major vascular complication, and that was not in a small femoral. And in the 11 patients with small femorals, there was no major complication so far. You will see from the baseline data that it was quite common also with calcification, with 44% of the patients with at least moderate iliac calcification. The first case here is to illustrate just that. You will see the images moving here. So we see the trimensio reconstruction on the iliacs, and if you trust the automatic measurement, it goes down all the way to 3.5. I think it would be fair to say it's 4.0 if you do manual measurement. There is a little bit of calcium, but not too much. This patient was really slim and light body weight. She also had a small annulus of just 20.4 millimeters and a very severe aortic stenosis with 5.6 meters per second tricuspid anatomy. So we'll see now the insertion from our routine room camera. of this sheath, and you see without excessive push or force, we can, in this fully awake patient, without any opioids, push in this 14 French sheath, and it comes up nicely without any pain reported by the patient. The next step, which I don't show here, is then to push the delivery system and the valve through, and that then completes the expansion of the sheath up to 18 French inner diameter. Here comes the valve deployment. This is just to illustrate how the valve is deployed with this two-step deployment. In the first phase, you will notice that the middle part of the stent expands. Usually there is a checking with contrast, and then the second operator continues with knob 1 until this, recheck the position, take away the pigtail, and then the last step is the number 2, and then the annular part will open quickly and come in contact on the other side of the annulus. This is the result in this patient with trace PVL on echo and also on the aortogram. So this highlights, I think, the use both in small anatomy, in the annulus, highly calcified, and especially with really small iliac vessels. And there was no complication while closing the groin, and there was no visible dissection in the iliacs either. The second case I wanted to show, I think the data, I was checking the bicuspid data of various devices. I think there is still a discussion about which devices are the best for bicuspids. We have, in our institution, we treated lots of bicuspid patients and with different devices. This particular patient was a patient with a 23.3 millimeter annulus. It was a bicuspid type 0, so it's the less common type, the so-called true bicuspid. There is some literature about measuring the intracommissural diameter. That was 25 millimeters in this patient. We chose a medium-sized valve, which is a 25 millimeter valve, and it's indicated for 23 to 25 millimeter annulus. So you could say in this patient, the intercommissural or the perimeter-derived measurement would come to the same conclusion. We predilate these patients usually, and for this patient, we used a 22 millimeter balloon. This is to illustrate the release and deployment of the valve. So we'll see in the first picture, phase number 1 or knob number 1 has been done, and you will see that the stent is protruding just a couple of millimeters into the LVOT. And you will see in the other picture the release step 2. And as it is typical, the delivery system, there is some push on it during the release, and it goes forward down to the ventricle a couple of millimeters during the release. The result is shown here. You see a rather high implant, a couple of millimeters into the LVOT, almost no leak. You also see quite horizontal ascending aorta here. We have in our institution done a fair number of cases with exactly this valve, the ACURATE valve in bicuspids. When I last collected the data, we had done 30, and only 2 of them had a moderate PVL. And for these patients with the ACURATE, we have done the sizing and the deployment exactly as with the tricuspid, which means we have relied on the annular measurements, and we have not excluded patients because of excessive calcium or type 0 versus type 1 anatomy, for example. The limitation here, of course, being that if you have an annulus over 27 millimeters, there is no valve from the ACURATE family which fits. So in conclusion, I would like to say that the ACURATE system, together with the eye sleeve sheath, allows you to do TAVI and have accurate results, even in challenging cases, especially now with narrow femorals, with tortuous iliacs, horizontal aorta, heavily calcified leaflets, and also with bicuspid anatomy in our experience. Thank you.
Thank you, Andreas. Maybe a first question. In which anatomical indication would an ACURATE be your preferred valve?
I'd say in most cases with an annulus up to 26.5 or 27 millimeters.
So basically, the ACURATE is your to-go-to valve.
Yeah, first choice.
Nowadays.
Yeah.
Okay, is that also with other?
Well, horizontal aorta, I believe, is a very good scenario for this valve because it nicely lies on the outer curvature of the arch and very nicely stabilizes from the right coronary sinus to the middle and opens nicely. So for us, that's a valve of choice. When Helge and I worked together, we developed this and used it routinely and felt this is better than any other valve, actually. Andreas, one question to your positioning. Well, my feeling is you're placing the valve pretty high. Is that right?
Yes.
We place it a bit lower, but your results were perfect.
Yes, we tried to place it at around 3 to 5 millimeters, so rather high. Yes.
Is there anything you can say about conduction disorders and need for pacemakers with ACURATE in your center?
Yes, we've done a study with a Swiss and a Danish center, which we published last year, and we found a pacemaker rate of, I think, 2.5%. So it's really low, and also the new left bundle branch block is also quite low, around 20%. So with this, I think the strategy we used was quite common. Maybe the implants were slightly high, but not on purpose high to keep the pacemaker rate down. So it's low.
Andreas, you showed us the results with the new sheath, with the 14 French system. Do you have any concerns in calcified vessels? So sometimes it's easy to bring in such a sheath in the calcified vessel, but once you try to bring the valve through, it may be difficult. Did you ever experience such a problem?
We have in 3 patients done ballooning of the iliacs prior to the insertion, or 2 times prior to the insertion of the 14 French and 1 time inside the 14 French, just to exclude the possibility of getting caught with the delivery system and the stent inside the sheath. Okay. I cannot really say if that was necessary, but it's possible to do it and seems easy to do also.
What is the predominant limiting factor for the femoral access? Is it the size or is it the calcium? So in other words, if you would have a vessel of 4.5 millimeters and there's no calcium, would that be a problem?
No. I think no calcium is, then you can go down safely to 4 millimeters and you don't need any extra procedures, ballooning or anything. If you have calcium also, quite a few of these patients with less than 5.5 also had calcium, but they did not have circumferential calcium. They might have had actually C-shape on the transection, and these were the patients where we ballooned.
Yeah.
One point. What's a pragmatic question? So, what's the minimum lumen diameter to get through with this valve, even though you use the E-sheath, the expandable sheath 14 French? Which is the minimum reference that you take to say, okay, this is safe, we can go like that?
4 millimeters, but if you have lots of calcium, you should probably balloon, and if you see that the balloon doesn't open up, then you know you have a problem. So far, we haven't seen that situation, but it could happen.
Small final.
4 millimeters, but the outer diameter is a little bit higher of the valve, so probably we have to take into consideration that the valve need to be really not too much severely diseased and calcified, otherwise you...
The outer diameter of the sheath, when you push through the delivery system with the valve, will go up to 7.3 millimeters, I believe. Yeah. So it gets considerably bigger when you push through your valve. That's true, like with the Edwards too.
We get more from Giuseppe in 2 seconds, but one final question for you. What is your preferred closure device?
It's the Manta device. All these patients are done with Manta and with micropuncture and ultrasound.
Yeah. Okay.
Manual compression.
Thank you very much. Thank you. So now I will ask Dr. Tarantini. It's up to you. Yeah. Now you can go for 10 minutes.
10 minutes.
Yes. And you're gonna explain the current evidence with the ACURATE and LOTUS.
There are a couple of people standing in the back of the room. So here are numerous free chairs, so please feel free to come in.
Okay, thank you, Nicholas, dear colleagues. So my task today is to share with you the evidence in TAVI patients with the use of ACURATE and LOTUS. This is my disclosure form. Let's start from ACURATE. Here you can see the list of the ACURATE Neo Transfemoral clinical program. Besides the first-in-man, the transfemoral 89, that is the number of patients that were enrolled in these CMARC studies, what we have to mention is the TAVI, transfemoral registry, that is a post-marketing registry that enrolled 1,000 patients, single-arm, 25 European centers, with a primary endpoint that was all-cause mortality at 30 days, and the secondary endpoint was the success and the device performance of the valve at 7 days and 1 year. And then we have to mention also the progress PVL. The first one, the TAVI, has been published. The second one has completed the enrollment by the early of August. Let's try to summarize very quickly the result of 30 days and 12 months of TAVI registry. As you can see, the all-cause mortality, all stroke, severe PVL, all of them are below the boundary of 2%. And then we have also, I think it's noteworthy, that the pacemaker implantation, the NIA class 3 or 4, is below the boundary of 10%. And I think it's important. You will see at the end of my presentation why. Related to the residual gradient is below 10 millimeters of mercury. Moving from the sponsor study to the published ones, here you can see the Moellmann study, that is a German study, is a 2-to-1 propensity-matched multi-center trial comparing ACURATE Neo and SAPIEN 3. About 1,000 patients enrolled in this registry, 3 only centers in Germany. Device failure and early safety at 30 days was the primary endpoint. The second trial is another German trial. We have 5 high-volume centers in Germany, about 200 patients enrolled, 1-to-1 propensity-matched multi-center comparison between ACURATE and SAPIEN 3, but the focus in this case is just small aortic annuli. The area was below 400 millimeters square. And this is the last one. This is a comparison among 3 different valves, ACURATE Neo, core valve, the first edition, and SAPIEN XT, about 150 patients, single center, and the primary endpoint was at 30 days. Let's review very quickly each of them, starting from the Moellmann 30-day result. The VAR2 safety and performance endpoints were superimposable between the 2 valves. Looking at the pacemaker rate and the hemodynamic performance, as you can see, the pacemaker rate was below the boundary of 10% again, and was better than that reported for SAPIEN 3. And the other part of the story that goes in favor of ACURATE is the residual gradient within the prosthesis. On the contrary, the SAPIEN 3 performed better, statistically better, in terms of severe PVL, 4.8% against 1.8%. Moving to the other German study, small aortic annulus, with 30-day 1-year outcome summary here reported in this table. As you can see, the early safety, all-cause mortality at 30-day and 1 year, pacemaker rate were superimposable, were not statistically different. The PVL was like that. And the difference was in the rate of severe per mega that was as low as 3% in this series related to the use of ACURATE. And again, the intrinsic intravalvular gradient were lower, and this is easy to understand because the difference between the outer and the inner diameter is close to 0 in this valve. The valve is supraannular and supracoronary, and for the SAPIEN there is a small difference of 1 to 2 millimeters, so it is normal by biophysics that is like that. The last trial has been published in 2017, comparison among 3 different valves. We can conclude that ACURATE Neo again compared favorably against the first edition of core valve and XT, but was associated, taking in consideration all these frequencies and number, that was associated with lower device success due to the higher embolization and migration and higher pacemaker rate. But we have to take into account that we're dealing with the first edition of core valve. Today, this morning, has been presented this study that is an iteration, a second iteration of the ACURATE Neo valve, is number 2. Accordingly, as you can see, the valve hemodynamic paravalvular regurgitation are really, really good because the intrinsic gradient is below 8 and the severe PVL is about 3%. Procedural success is close to 98%, and putting together all the complication overall is less than 5%, and the death plus disabling stroke together, pulled together, is below 5%. So I think it's important to state that this valve is simple, but we have to respect that we have a learning curve. Also for this valve, likewise the other prostheses. And this is a very nice study, JACC Intervention 2018, that shows that when you use this complex index, that just say that when you go to improve the sizing and the positioning, you have to do at least 100 cases. When you skip these boundaries, all these index, that means you are much better, in intervention in terms of sizing and positioning, and you can see that the coverage and all the other things like the leakage, etc., are significantly more in favor of those interventions that skip and overtake this boundary. And this parallel also the outcome, because the 30-day mortality dropped down from 5% to about 1%, and the device success, PVL, dropped down significantly. So learning curve matter. Let's try to swap very fast forward to the LOTUS. This is the evidence. This is a full list of all the trials that we have, REPRISE 1, 2, and 3. This is a CMARC study, 250 patients enrolled, 3 different valves, and the primary endpoint is the 30-day mortality. Then going down through the RESPOND trial, we have to mention absolutely the REPRISE 3, that is a pivotal study of FDA approval in high-risk inoperable patients. This is a randomized trial, enroll 1,000 patients, more or less, and the comparison is between LOTUS and core valve. Half of them are Evolut R, not Pro, in this kind of trial. And then we have the REPRISE Japan. Again, this trial is being presented this morning. This is the REPRISE 2 4 years follow-up, just to highlight that the paravalvular regurgitation is as low as 2% at 4 years. That is absolutely impressive. And then we have also the NIA class that improves significantly and is quite steady throughout the follow-up. The mortality at 4 years is 19%, and the stroke rate is as low as 6% at 4 years. So moving to the REPRISE 3, here we have 1,000 patients. This is a non-inferiority trial, a 30-day, that was the preliminary analysis before coming and waiting for the result at TCT 2019. What we have is that we have the non-inferiority between LOTUS and core valve is met, but the LOTUS seems to be better in terms of primary efficacy, 16% against 26%, the overall outcome. The disabling stroke is half than that's reported with the core valve, and the moderate or greater PVL, everybody has experience on that, is 8 times less because of the footprint, the closed cell design, etc. And then there is a reduction also in repeat procedure, TAVI, and valve malpositioning. On the contrary, core valve is better in terms of valve thrombosis, pacemaker rate, that is about 30 to 35% for LOTUS against more or less 20% or with the core valve. And the gradient, intrinsic gradient, again, is 8% for the same reason that I told you before, because the difference between the outer and the inner in the LOTUS valve is about 3 millimeters, so it's not 0. So we need to take into account this. At 1 year, this is Ted Feldman that has presented 1 year result in stroke rate. As you can see, the stroke rate of the LOTUS is less in this trial, in this study, compared to core valve. The result at 2 years are going to be presented at TCT 2008. My 3 last slides. This again has been presented during the PCR London valve, just to show up again the same story. The gradient is 40 millimeters of mercury, that is higher than that of ACURATE because of the reason that I told you before. The PVL is close to 0. There is a low death and stroke rate is about 5%, and in 97% there are none of trace paravalvular leak. The rate of pacemaker is 15%. I don't I don't think it's related to the fact that we're using the LOTUS age in this case, but I think that we have to wait. There is something promising, but we have to see. Let's try to summarize all this data. This is all the trial that we have across the valves and with different type of patient follow-up, etc., and different generation of valve. Let's try to summarize in one picture. Looking at the pacemaker, where we are is we accurate. We are about 7% against 26% on average with the LOTUS and 12% of the other global leaders that include the SAPIEN and the core valve. Moving to stroke, that is, some of the major interest of Nicolas. At 1 year, what we have, this is the summary, is 5% with ACURATE, 6.8% on average with LOTUS, and 7% with the global leaders at 1 year. We know that even with partner 2 is 6.8. So this is the reality. Moderate to severe PVL at 1 year, 4% with ACURATE, 0.5, 10 times less with LOTUS, 5% with the global leaders at 1 year. I would like to conclude with this slide. This slide has been proposed by Martin Leon 1 year ago, just trying to set up the standard to tackle the new market of low-risk patients. So this is the proposal of new performance benchmark for a valve, mortality 1%, stroke rate 1%, major complication less than 3%, new pacemaker less than 10%. Did you remember that's the boundary that I told you during the first slide, and the moderate PVL below 3%. What we might say is that we accurate, we are in the right direction. I don't want to make any inference on stroke rate because I think it's strongly the rate of stroke rate. The stroke rate is strongly influenced by the baseline risk of the patient, and we don't have data on ACURATE in very low risk of patient. And moving from ACURATE to LOTUS, I think again we are in the right direction for mortality, complication, and PVL, but probably some work has to be done related to the pacemaker rate. Thank you for your attention.
Giuseppe, thank you very much for this very good overview on the clinical data. Are there any questions from the audience? If you could design the perfect valve, what design features would you like to combine in order to overcome the different problems?
Okay, thank you, Olga, for this point. I think it's very important because what I think that in the next upcoming future is not too late. I think 2 years, 3 years. What we have to think is not to the inoperable patients that are important. It's an important market for sure. But I'm afraid that with the restricted financial resources, I'm afraid that might be again forgotten patient. But the point is intermediate to low risk patient and the expectancy of life. So we need to get rid of all the potential complications that we might have in the follow-up. So for me, the pacemaker rate, the possibility to re-engage very easily the coronary artery, the stroke rate, etc., need to be the main, pillars to drive the design of the future valve. But probably already we have to wait for new data. So I don't know.
What about the difference in stroke rate in the Reprise 3? Because that is somewhat troubling me. What would be the reason for that at 1 year? Why would you see more strokes with self-expanding versus the mechanical?
Yeah, this is interesting, but I would like to give you a smart answer, but I don't have a smart answer. I just gave a look at this data. In this case, I don't know. Probably it might be related to the fact that with the LOTUS, in my experience also with the LOTUS Edge, you don't need to pre-dilate, post-dilate to do other things. I don't think it's just a matter of crossing the arch. I think that there is a role also of the manipulation that you do to the valve. In this case, you have a mechanical expansion, and the radial strength was stronger than the other one. So most of the time, I didn't have any need to post-dilate. But I don't have a smart answer, as I told you before.
Well, I think it was also remarkable that the difference became more apparent at 1 year, not at 30 days. So probably it is a play of...
AFib, probably.
Well, I think it's a play of chance.
Play
and
of
I
chance,
think we
might
have
be
to
AFib
overinterpret.
also. But I don't know why there is difference, because shouldn't be.
Exactly.
But we have to look into the data, but I don't have the data set, so I cannot answer to this point.
Okay. Thank you very much, Giuseppe. Thank you. So now I would like to invite Jolinda Mehili from Munich to discuss the closing evidence gap in emerging TAVI populations. Jolinda.
Thank you. So, ladies and gentlemen, it's a pleasure for me to present now data for closing the evidence gap in emerging TAVI population. Here are my disclosures. So before speaking about closing the gap, I just want to tell you what is the status of treatment of aortic valve stenosis. 70% of the individuals with severe aortic valve stenosis are symptomatic individuals. And trusting to this data just published at the European Heart Journal, nearly 40% of these individuals are not referred for surgical aortic valve repair and might be potential TAVI candidates. However, on the other side, as you can see, that even these TAVI candidates, nearly 40% of them are not referred to TAVI. So what is the reason? One of the reasons are the differences in socioeconomic resources within the different countries in Europe and in North America. But another reason might be also the fact that we, in many subgroups of aortic stenosis patients, do not have enough evidence or very few evidence. And I put it here together, the different subgroups of aortic valve stenosis, showing that patients with severe stenosis, with a high gradient aortic valve stenosis, being symptomatic and having a STS score more than 4, practically we have randomized data showing us that TAVI is the best treatment option. But coming to asymptomatic patient, to patient at low risk, or patient presenting with low flow, low gradient aortic valve stenosis, or with regurgitation or bioprothesis failure, we still do not have enough data. Let's talk about patient being at low risk. And I used here the data of a meta-analysis of 4 randomized trials, nearly 4,000 patients, mean age of 82 years old. Mean STS score between 8 and 4%. Particularly the Notion and Partner 2 trial included intermediate risk patients with a mean STS score of 4%. And at long-term follow-up, this patient undergoing TAVI have a significantly lower mortality compared to SAVR. Even in the patient with a low, let's say with a mean STS score of about 4%. However, these data are only hypothesis generated and led to 2 randomized trials, which are ongoing, the Partner 3 trial, comparing TAVI with SAVR among patients being more than 65 years old, having an STS score between 2 and 4%. And another trial, the data of this trial will be presented this year because the inclusion of the patient is already finished. Another trial, which is also an important German trial, is the DEDICATE trial. To remind, these trials are also included patient at low risk or intermediate risk with an STS score between 2 and 6%. And to highlight, this trial has no age limit for the patient. So if we expand the TAVI indication into an STS score of less than 4%, what does it mean for our patient? So under current condition today in Europe, there are 110,000 patients suitable for TAVI. And if we expand this indication to a low-risk patient, it will be nearly 180,000 patients. So we have still under treatment of this patient. However, speaking about the younger patient and low-risk patient, we have to be sure what kind of prosthesis we are using. And to evaluate this, we need randomized trials. You have seen we have self-expandable valves, we have balloon expandable valves, mechanically expanding valves, and etc. And all these different designs need to be compared with each other before deciding for a certain valve. We have 3 important randomized trials performed to compare different designs. One of the first one is the CHOICE trial, which did show that with the balloon expandable valve, we will have a higher, significantly higher device success compared to self-expandable valves, which was related particularly to a significant reduction of paravalvular leak. The other trial was the REPRISE 3 trial, 912 patients comparing the core valve with the mechanically expanding LOTUS valve. You heard about the data of this trial. LOTUS valve was superior to self-expandable core valve regarding the reduction of perivalvular leak, moderate perivalvular leak, only 2% with the LOTUS. Another small trial terminated prematurely is the REBOOT trial, which compare now the LOTUS valve with the SAPIEN ST valve, showing again less paravalvular leak, any form from paravalvular leak with the LOTUS valve compared to the SAPIEN 3. But what happens at the long-term follow-up? Looked at the choice data. At long term, we have an opposite result. We have much more stroke with the SAPIEN valve compared to the core valve. If we see the REPRISE 3 trial, we see that with the LOTUS valve, which has less paravalvular leak, we have a higher transvalvular gradient compared to the core valve. And particularly, this higher transvalvular gradient is among the patient with a small annulus. If we see the REBOOT randomized trial, we see that we have the need for new pacemaker above 40% with the LOTUS compared to only 18% with the SAPIEN 3. So, as you see, we have different complications, we have differences in event with this valve, which make none of them being the perfect one. However, many of the complications we experience with this kind of valves are modifiable complications. And you saw the data from Giuseppe Tarantini regarding the pacemaker rate. And here is a review just published in European Heart Journal showing how different are the pacemaker rates with the different valve types, with the ACURATE now being the one having the lowest pacemaker rate, below 10% in each of the registries published today. Also, I put some data here coming from a propensity score matching from the Rudolph group, showing that with the ACURATE now, compared to the SAPIEN valve, we have lower transvalvular gradient after the implantation, particularly in small annuli, which is very important because lower gradient, which means longer duration of the valve. And also the prosthesis patient mismatch is much lower with ACURATE Neo. Only 40% of the patients have this prosthesis patient mismatch compared to nearly 70% of the patients with SAPIEN 3, and these are all patients with a small annuli. So with the modern valves, we have the possibility even to improve further our data. That's why there are 2 randomized trials ongoing, the SCOPE 1 and SCOPE 2, comparing the ACURATE Neo valve with the SAPIEN 3, the SCOPE 1, and ACURATE Neo valve with the core valve Evolute in the SCOPE 2 trials. The result will be in the next year. Now, an important subgroup of patients with aortic valve stenosis are patients presenting with low flow, low gradient. There are nearly 30% of the TAVI patients we are already treated. And one of the most important subgroups is the subgroup of patients with the so-called paradoxical low flow, low gradient aortic stenosis, which are patients with a pronounced hypertrophy of the left ventricle. Majority of them are women. They have very small aortic valve annuli, are patients having a preserved ejection fraction, but with a low stroke volume. In the registries with the TAVI, nearly 10% of the patients have these features. But if we see the registries in which many of the patients are treated conservatively, this kind of patients are nearly 30% of them. So what's happened with this patient? Here at this meta-analysis, you can see that the mortality of the patient with paradoxical low flow, low gradient aortic stenosis is 70% higher compared with the traditional high gradient severe aortic valve stenosis. And if we want to put this in numbers, I brought here the data coming from partner randomized trials showing that the inoperable patient having a paradoxical low flow, low gradient aortic stenosis have nearly 80% mortality at 2 years, which is reduced with the TAVI at 56% at 2 years mortality. Even patient at high risk is a small group of only 90 patients within the partner trial, showing that they have a 40% mortality risk at 2 years, independent if they are treated with surgery or with the TAVI. So it's a group of patients being at high risk for mortality. And looking at the registry data, retrospective registry data, doing aortic valve repair, you will reduce the mortality in this patient by nearly 50%. However, All these registries are retrospective registries. The definition of paradoxical low gradient aortic stenosis is very variable. There are mixed treatment strategies. Some are TAVI, some are surgery. There is a selection bias of the patient and everything. That's why we need a randomized trial. And we designed the Reboot Paradox trial, which will answer this question. Half of the randomization sequence will be 2:1. 780 patients will be randomized to receive either aortic valve repair on top of the optimal medical treatment or optical medical treatment alone. And the 2 years, the primary endpoint will be all-cause death. The study will start in 2019, and our default TAVI will be the ACURATE Neo with SAPIEN in cases anatomically difficult. Now, to summarize, a lot has been done regarding providing evidence for performance of TAVI in patients with aortic valve stenosis, and many things have to be done. We have many randomized trials for patients at low risk, patients with classical low-flow, low-gradient aortic stenosis, even for asymptomatic patients. We have future trials like Reboot Paradox with 780 patients, or EVE TAVI in asymptomatic patients, 1,420 patients. And also we will have the answers regarding the therapeutic option after TAVI in the years to come. Thank you very much for your attention.
Thank you very much, Yolanda, for giving us this overview, and especially the second to the last slide with the green lights and red lights is very promising, because we already have a considerable share of green lights. Therefore, we are good to go for many patients. Are there any questions from the audience? You had a question.
Yeah, I have a question in terms of suitability of the valve platforms. Do you think that every valve platform is suitable for each expanding indication?
I don't think so. I don't think so. We have enough evidence to show us, for example, for the LOTUS valve. LOTUS valve is a valve which has a very high pacemaker rate. We don't know what happens with the pacemaker patient, particularly if we are using them in the young patient. We still do not have any evidence that the presence of pacemaker is increasing mortality. Until now, we don't have this evidence, and it seems to be safe. But however, we don't know what happens in the young patient, the first one. The second one, we have to pay attention to small annuli. Small annuli are very sensitive to transvalvular gradient. If we have intra-annular positioning valves like SAPIEN, like LOTUS, they are all intravalvular positioning valves. In this case, you will have at the end of procedure a transvalvular gradient in small annuli, which is much higher than with the supraannular positioning valve. And this is important to take into account. That's why we decided, for example, in the Reboot Paradox to have the ACURATE Neo as the default valve, because we are waiting there to have much more women with small annuli. Another option is that we have to highlight is also the fact that the intra-annular positioning valves, SAPIEN 3 LOTUS, are valves which have much deeper neosinus. With positioning of the new bioprothesis, with preservation of the old valve inside, you have some kind of neosinus. And in this neosinus, you will have a higher risk for thrombosis. So a supraannular implanted valve has a lower risk of stent thrombosis because the neosinus will be the smaller one, and the washout will be much faster. So even these things we have to consider when we select the valve.
Well, it's remarkable that you mentioned the neosinus, because in the Reprise 3, the thrombosis rate was, the stroke rate was lower than with LOTUS versus with the core valve, but indeed there was more stent thrombosis in the LOTUS arm.
Yeah, there were more stent thrombosis on.
When we are talking about gaps of evidence, then we automatically come to the longevity thing. Do you really believe that we need more data, or is that what we have right now already enough in order to go into low-risk patients, into younger patients?
Thank you for this question, which is very important. I think the data that we have today is particularly limited due to the selection of the patients we have put TAVI inside. The majority of them were high-risk patients. The mortality is very high. you see that we have some data published this year. Elchaninov published the first data of 10 years data from the first patient, showing very few patients remaining alive until 8 years or 9 years. So we still do not have enough evidence for durability of these valves, because the collective, when we put the valve, was a very sick one, and not representative for the collective where we are putting the valve today. So we are going today probably not too fast below with the age of the patient. We still are remaining to the 80 years old patient, but we are working today in patient who has a long life longevity because less comorbidities. They are low risk patients. They will live at least 10 years. So I think we need to accumulate the data of the patient we are treating today before we go to patient below 70 years old.
Melina, when we talk about low-risk patient, don't we have to differentiate between low-risk but old? Because age alone doesn't make risk. An octogenarian, an 80-year-old patient, is usually a low-risk candidate according to the STS score. He will have an STS score between 1 and 2. So we need to differentiate between low-risk plus old and low-risk young. Yeah. And especially in the young ones, what Helge said is extremely important, the durability of those devices and the potential options for valve, etc. So I believe there's quite some evidence gap still, but we're on a good track.
Yeah, I completely agree with you that the age is the first divider of if we do a TAVI or if you do surgery for aortic stenosis. And you saw the new guidelines have a cutoff age of 75 years old to decide if we prefer TAVI or we prefer surgery. And I completely agree with this, because speaking about a young patient, low risk is another type of patient. Majority of them have also a disease of the aorta. Majority of them are bicuspid valves. And we also do not know what kind of durability on these valves in this patient we have.
Can you give us any idea, like you mentioned, the 2 trials that are going to be presented at ACC next year, Partner 3 and CoreValve low risk? What's the age group or the age inclusion criteria? Do you know already, or is it public? I don't know.
As I know for the Partner 3, that the cutoff age is 65 years old.
But what's the effective age of the population? That will be the interesting thing.
I don't know it.
Can I make a couple of comments on that? So this is a very important point, because the risk does not mean younger, and this is for sure what we have by the data, because whatever is the risk of the trial, the common thread is that all the patients are above 79 years old, 80 years old. I am afraid that the Partner 3 won't answer to this point, because there is no stratification for age, and the randomization is not stratified for a pre-specified age. So I'm afraid that even though the patients are at low risk, the average of the age of the patient will be 77, 78, 79. The only trial that has this option is the Notion 2. In the Notion 2, the randomization is stratified according to the age of the patient. This is the first comment, and I think is absolutely of utmost importance to have on board this kind of patient. The second point is about the durability. We have to remind that recently in a PCR has been presented the Notion 5 years, that shows that at 5 years, I don't know how long is the life of my life or the life of Nicholas, but at 5 years, what we have is the primary degeneration is 5% for TAVI, is 26% for biological surgery. So I think we have to start to breathe and relax, that the data are absolutely in the right direction of the patient, not the right direction of the interventional cardiologist, because this prosthesis works in the right way. So that's, I think, is important to share with the audience.
With that, I would like to thank you and you for this wonderful talk. And we...
Wonderful. Yeah, 5 years already
And we have to go on. The next speaker is Dr. Kabanda, and the speech is about the implementing an efficient TAVI program and a recorded case from John Radcliffe Hospital, Oxford, UK.
Good afternoon. Thank you very much. So thank you for inviting me. I'm going to start with a short video to introduce the team, because efficient pathways rely on good teams. So, in terms of our transition over the past 4 years, we've increased our TAVI activity fourfold.
So we're now doing 4 cases a day rather than 2. It means we're doing 200 cases a year rather than 50. It means that the cost per case has gone down.
It's about streamlining the cath lab process itself.
We made an investment in conscious sedation, local anaesthesia, truly percutaneous.
So we moved to ultrasound-guided vascular access as part of our percutaneous strategy, and our rate of needing vascular surgery has fallen from 7-8% down to 1% only with our ultrasound technique.
Time you invest at the beginning will be made up at the end.
Sedation has had a massive impact actually, and that's the aspect that's allowed us to then treat genuinely urgent cases.
Currently, we're using the ACURATE Neo valve as our workhorse valve.
My experience with the ACURATE valve has been really very positive.
We've done a consecutive implant of over 100 of those valves, and the key advantages of that system have been the marked reduction in the need for permanent pacemaker implantation. Marked reduction in the need for permanent pacemaker implantation.
The catheter tracks extremely well.
So all of those steps have incrementally reduced our complications and improved our efficiencies. We have a very full and comprehensive MDT, which has representation from care of the elderly, anaesthesia, surgery, cardiologists, and interventional radiologists.
Conducting a good MDT relies on good relationships.
Communication is key.
Having the patient in the center of the discussion.
We all just do everything together.
They realised quite early on that it would be good to get a geriatrician's input into the MDT to decide, are the people that they're being referred the correct people to undergo the procedure?
It's investing in your multidisciplinary team.
And that, as a geriatrician, warms the cockles of my heart.
You need a consistent TAVI team.
A helpful,
progressive,
friendly,
consistent
and cooperative team.
I think we've been fortunate that the core members of our team have really been with us for the entire 8 years now of our TAVI programme.
And therefore we've all got to know each other's strengths and each other's skills.
And that helps both to build up the team dynamic, but also the shared learning.
So I think one of the challenges for us is where do we go next? I think the key thing is predictability. Positioning the valve, making sure we don't cause stroke, and vascular access. They're the 3 important things for me.
Good. So I hope that's woken you up. We've had a lot of discussion really about where TAVI is going, what risk factors, it's transitioning, but the healthcare providers are really concerned about TAVI. It's expensive, and we therefore need to maximize efficiencies so we can deliver these treatments. Efficiency, however, depends on where you are. And in this audience, there'll be people that have national roles, there'll be people that are trying to work out regional services, hospital managers working out hospital efficiencies, or your program, or your cath lab. And those stresses and what you call efficiency are therefore very different. In our unit, we had a 3-fold increase in referrals over the past 4 years. As you heard, we've increased our activity 4-fold over those 3 years. And these are the things that we want in terms of procedural efficiencies. We want a predictable procedure in terms of the valve, which we've been discussing, but also in terms of the complications. And stroke, pacemaker, and vascular access are the key things, I think, that are going to focus on how we deliver efficient pathways. I'll talk you through what happened in Oxford. So we had a surgical era with 14 people in the lab. It was general anesthesia. It was cut down. We switched to a percutaneous sedation, conscious sedation, anesthetic-led with ProGlide closure, reduced the length of stay. We then went to an ultrasound-guided approach. We had a series of vascular complications, and now we use routine ultrasound. That led to less access site complications, and you can see there a major reduction in that. And then at the latter part of last year, we went to routine left ventricular pacing. We removed the right ventricular pacing from our protocol. We used the eye sleeve, and we went to the ACURATE Neo valve, and we've reduced our pacemaker rates now as well. So these consecutive and incremental changes have really contributed to why we can deliver this. But you do need a team. It's not a single person sport, this. You need the whole infrastructure and the whole team around you. So I'm going to discuss a couple of cases. So this was an 82-year-old lady who was being followed up at a district general hospital for her aortic stenosis. She was admitted as an emergency following a 1-month history of progressive breathlessness, presumably precipitated by her drifting into atrial fibrillation. The CT was suitable for transfemoral access. The calibers were not like the ones we've heard. They were very suitable for access. The key issues with this case were the horizontal aorta and the low-lying left main at 8 millimeters. So the next video really is a case illustration of what we do. So ultrasound-guided vascular puncture, as I say, is our routine. You can see the case time there. One of the criticisms we often get is, oh, this increases my procedure time. It's a skill you need to learn. We've got less progride failure. You can target the puncture. You can avoid calcium. And that facilitates passage of the sheath. And I think it's a good skill to have. So 12 minutes into the case, we're doing our check aortogram. We've, as I say, removed the right ventricular pacing wire. We do still have venous access. We have a venous line. We put a wire into that just in case we need to pace quickly. But we don't introduce a right ventricular pacing wire. We routinely pre-dilate for our ACURATE neo cases. The passage of this catheter, the delivery of this catheter is really very, very quick. It doesn't have the same resistance as some of the other devices. We're going to go into audio here in a second, so this is a sort of live case recording of a real-time deployment of this valve.
Sometimes find with these sort of aortas, it kind of goes in and then slips back a bit.
Okay, ready?
Yeah.
Oh, that's perfect, isn't it?
Good. I agree, I think it's spot on. Your marker band's right on the annular plane.
Let's just check we haven't moved. Yeah, that's good. So slow release.
Start to initiate that process.
Slow, slow, slow. Nice, stop there. Just check we haven't moved. Stop there.
Looks stable.
Check we haven't moved. That's very good. Okay.
Looks nice.
We complete phase 1, I think.
Completing phase 1 now.
I'm just holding on. I'm holding on absolutely still, making some micro adjustments if there's any movement.
Completion of phase 1. Do we need to leave the catheter in, Jim?
No, I would take one more picture and then take the pigtail
let's
out.
do a big aortogram here, and we're looking for a pacification of the left coronary. Ready? And on. That's great. So.
Looks nice.
That's lovely.
Pigtail away then.
Pigtails away then. Hold this catheter tight.
Yeah. That's good. Ready for phase 2.
Off you go.
Okay, that's good. And go. Lovely.
Phase 2 complete.
Fluoro, grab that please.
Good.
Rhythm stable, pressure's stable. Let's just do an aortogram. So
let's just get the device up and out.
So centralise the wire. Okay, that's good. Push that. That's lovely. Well done. Okay, that's good. Off mag. That's good. So 2 blind.
We'll do your aortogram now.
Okay, that's good then. Ready?
No. Yep.
And on.
Lovely.
Okay.
Beautiful.
Lovely.
So just tell us what you're seeing there, Jim.
So the first thing I want to look at in this case is the left sinus filling, and it clearly is, and is the left coronary pacifying, and it clearly is. And you can see the calcification on the left cusp has fallen well short of the left main, so really no risk here of coronary occlusion. The valve looks well expanded. It's just slightly pinched in on this side from that boulder, so again, is there any AR coming in here? I can't see any in the aortogram. We'll check on the echo. But the height and the position looks spot on.
And we can see right coronary perfusion as well.
Right coronary is fine, yeah, and it's well out of the way.
That's great, isn't it? And the upper crowns really have kept that calcium down, haven't they?
I agree.
You can see that it's below that.
Gradient is excellent. Trivial
Any
AR.
regurgitation there, Jim? Even with the wire in?
Just trivial.
6 French angiosil, please, for the other side.
It's good.
That's great. Okay.
It's great.
Well done. That's all gone very, very well, all right? You should feel better for that. So that was an urgent case, horizontal aorta, low left main, case time of 38 minutes, no coronary obstruction, and the ECG was unchanged, narrow complex atrial fibrillation. And that sort of you can deliver with the incremental anesthetic-led sedation, ultrasound. You know, we're confident we can get good results in terms of closure and with this valve. So what about something a little bit different? This was an 80-year-old lady, background of COPD, severe calcific aortic stenosis, surgical turn down in our case, quite marked conduction abnormalities on her ECG. And her femorals in our practice were not just small caliber, but had extremely long lesions, quite a lot of calcium, which really put us off a transfemoral access. So we opted for a left axillary approach using an eye sleeve and an ACURATE Neo. We did this under general anesthesia. She had prior LAD angioplasty and the implant of a right-sided pacemaker. The left axillary is a better access for the valve. Percutaneous ultrasound-guided axillary puncture, and I'll show you that video of that case. So we are early in our experience with this, but the lateral axillary approach under ultrasound is quite a safe puncture site. We used the eye sleeve, which we didn't push all the way in. We just introduced it and left it hanging out. And then it was a standard approach with pre-dilatation and deployment of the valve. Now, the key things, there are some subtleties and some adaptations you need to make. There is a sort of a telescoped introducer sheath, and you'll see here we're holding the introducer sheath at the end and the sleeve. Don't hold it in the middle. Placement there of the valve, and it's a really very stable position, and along the outer arch is really a very good way to deliver this valve. We did need to post-dilate this. I think if I was being critical, this balloon's probably a little higher than it should have been, but it did drift up. But actually, we've got a very satisfactory result with that, with a case time of under an hour there to valve deployment. And then it was a ProGlide percutaneous closure, and that concluded the procedure with a check angiogram at the end to show no trauma or subclavian or thoracic bleeding. So, and that's her at there. So I think there are some key features with this catheter, with this valve, that make it very suitable, as we've heard, for some complex cases. What's next? Well, I think early discharge is something that we are really needing to think about, particularly in our healthcare system. Is it safe? We've looked at patients who might be eligible, and if we had discharged patients appropriately, we might have saved about 500 bed days. So that's something we're keen to look at. This is what we're all trying to understand, isn't it? The right procedure, the right valve for the right patient. And I'm going to bring this back to the patient in terms of most patients have concerns about their quality of life, and this reference really illustrates that rather than staying alive. And I'm going to show you a final couple of minute video giving us a patient perspective.
If you asked me 15 years ago, are there lots of elderly patients out there with severe aortic stenosis who are not getting treated? I would have said no. I've had the enjoyment to meet some remarkable older people who've barely been in hospital, who now are very restricted.
How have things been?
Well, they're really getting worse.
We've been able to treat and restore them to fantastic qualities of life.
Well, I get breathless if I do too much. I am over 80, so naturally one slows down a bit.
I love to see a patient come in, have an aortic valve replacement, awake with local anaesthesia in 45 minutes and be having a cup of tea and a sandwich an hour later.
With a bit of luck, if the team gets their stuff right, I'll be good for another 10 years.
The important thing here is that their quality of life improves, and this is what here to provide them with.
I said to him, "Oh, am I going to be a guinea pig?" And he said, "Well, no, actually, we've got rather good at this."
And I think for elderly patients coming into hospital for big procedures, removing a lot of the more daunting aspects of their time in hospital has had a huge impact on their experience.
How are you, Professor? I'm feeling much better, thank you.
Already?
Already.
The top drawer. It is the immediate post-TAVI phase where our patient says, like, you know, I'm not short of breath anymore. I feel wonderful. Like, what have you done to me?
It was quite fast.
It was quite fast.
it's that satisfaction in their face, it's the joy in their face.
And patients routinely come along and talk about this being life-changing.
It is amazing. That's what I want to do, yes, get on with my life. But I'm free.
Unbelievable and amazing technology.
I'm very grateful to be alive at a time when it's possible to do this.
And being able to take patients who have developed a very serious condition and are extremely limited and get them through a procedure comfortably, quickly and safely and have them return to clinic grateful for that treatment is what drives me forward.
So that's fine. I'm going to stop there. Thank you very much.
Excellent, excellent presentation. Also nice white spectacles you were wearing during the procedures, flashing. So what is the portion of the procedures that are being done now under local anesthesia?
That's
so no general?
Our standard approach for transfemoral is almost 100% anesthetic-led sedation, local anesthesia. So we would do, auxiliary cases we're doing under general anesthesia at the moment because we're early in our experience. But our plan is to switch those to local.
Yeah, so I agree with that. It's the same in Rotterdam, and indeed we do our transaxillary cases under local anesthesia. Yeah, so it's feasible. It's definitely feasible. Is the alternative access with the ACURATE more difficult than a transfemoral, or it doesn't matter?
So it's been very good for us. I think the sheath flexibility is really very good, particularly for the axillary puncture. And we've done a couple of right-sided axillary cases. And that top turn, which has been a challenge with other valve systems, with the flexibility of the ACURATE system, has really been very straightforward. Mm-hmm. So I think from that perspective, that's been very reassuring. Yeah. But valve positioning is important. But once its upper crowns are released, the valve system's really very stable.
Mm-hmm. So Thomas, what is your preferred alternative access strategy now, and what device do you use then?
What do you expect? I still believe.
I hope no longer transapical. I hope.
It's straightforward. You're just not doing it.
You mean it's transapical?
Straightforward, yes.
Oh my God.
And safe.
So I think in terms of efficiencies, for us, we had to cancel about a third of our transapical cases because of ITU beds, prolonged stay. And if we're cancelling cases, rescheduling them in terms of efficient programs, it was getting very challenging. And I think it depends on your healthcare system, where you are, your beds. For us, we needed a system where we didn't need ITU beds. We could move patients through much more quickly. And that's why we had a transapical program, but in order to improve our efficiencies and get this done, we had to think of alternative percutaneous access ways.
Yeah. And how's it going with you, Giuseppe? Alternative access, what is your preferred route? In the microphone.
Because when you go down, actually in my institution we have more or less 95% more, I think 97% with transfemoral. Other alternative axes are, the peripheral axillary access, and then still leave, I think, the transapical in really tough situation in terms of peripheral artery disease. But for sure, transfemoral now might cover more than 95% of the procedure.
Thank you very much for your presentation, and then Helge will do some final remarks. Thank you.
So I have just a couple of slides for the final remarks. So we had a very good session with important talks. Nick started about the embolic protection, and if you have a look on these images, it's pretty intuitive that it might be a problem if the debris comes into the brain, and therefore it was pretty convincing on how you showed us the results. The next talk was from Andreas Rück, and it was about expanding the possibilities for TAVI, and here especially what you can achieve with smaller sheaths. And here's one image about the iSleeve Stockholm registry with a very good rate of success, all in very small vessels, as you can see here. Then we came to the current evidence, and I just borrowed the two slides from Martin Dion for the ACURATE and the LOTUS here. And I think the current evidence is already pretty good. Of course, we do still have to work on it, and Jolinda Mieghem gave us an insight on what was already done and what is about to come. And you can see that there are a lot of green dots here, so we are already pretty well equipped with published trials, but there are still questions which have to be solved. Last but not least, it was about the efficiency of a TAVI program, and there are different aspects on how to make the TAVI program as efficient as possible. One aspect is to get the people home as soon as possible, as you can see here. So I do hope that the different aspects of the different talks were interesting for you. I wish you a pleasant Monday and tomorrow a pleasant Tuesday. And for that I have a save the date here, as you can see here, for another symposium which takes place tomorrow at 1 o'clock in room number 4. This is the room on the other side, if I remember correctly. 1 o'clock, cerebral embolic protection from emerging technology to standard of care. Thank you very much.